I want to move on now to the more elderly patients and just ask very quickly with a sort of short answer, what's your go-to regimen for an elderly non-transplant candidate patient, Raphael?
So just as of the last ASH meeting, I've switched to daratumumab, lenalidomide, and dexamethasone. I use quite a bit of RVD light, meaning just attenuated doses. It's always the dealer's choice how we do that. Usually lower doses of dexamethasone, usually a lower dose of lenalidomide as well too. And those are the two regimens that I would say I would use the most. Occasionally RD in the very frail patient.
And for you? You said KRD earlier, are you sticking with that? Or?
Well, if patient, in my judgment and assessment, is too high risk to go on KRD, I am almost certain I will switch to DARA RD as my top choice. And flipping between DARA RD and RVD will be probably what we will be struggling over the next year or two.
DARA RD, you've both mentioned that, and just in the New England Journal of Medicine this week, the results of the MAIA trial were published. Tell us what that showed, Raphael.
Well, so the MAIA is a phase 3 randomized comparison between daratumumab RD, lenalidomide, dexamethasone versus RD, lenalidomide, dexamethasone. Huge improvement in progression-free survival, not yet reached, and it's not completely estimated when that's going to cross. Versus lenalidomide, dexamethasone, which actually turned out to be a good regimen. This is something that obviously has changed the paradigm of how we think about the transplant-ineligible patients, because before this, the only study that could get close to it and doesn't quite do it is the SWOG study that you mentioned before, the combination RVD. Short of that, you look at the historic data with melphalan-containing regimens, I'm going to say there's no reason why anyone should ever get melphalan again, with the exception of, at the international level, people who may have access to daratumumab because of the Alcyone being approved as a combination for the transplant-ineligible. The results of Alcyone are actually quite good.
What is Alcyone? Maybe we'll just for variety have you tell us about that one.
Yes, this was a study which was already published and updates were presented in which previous standard of care in many countries, in most of the European countries, VMP for elderly patient, VMP is bortezomib, melphalan, prednisone, was a comparator, and experimental arm was VMP plus daratumumab. And it was a very strongly positive study, regimen to regimen. VMP was given as approved for 9 months of therapy. VMP plus DARA was also, backbone was also for 9 months, but then daratumumab continued, which may be part of the impact of daratumumab for the results which we have seen. But the study was strongly positive in regards of almost all categories. Progression-free survival strongly improved, depth of response, MRD negative disease. That was the first approved daratumumab antibody containing regimen across multiple countries. So big breakthrough, and MAIA, I'm sure, is going to follow as a next regimen in frontline setting.
Both of you have talked about daratumumab, lenalidomide, dexamethasone in the elderly population. Are you worried that there's no proteasome inhibitor then in the first 2 or 3 years of their treatment?
You know, I don't think so. And in fact, what's interesting, even if you break it down by risk, I said that the confidence interval is there, but there's not a significant difference from what we see with other proteasome inhibitor containing regimens. So it is a big question. I think I mentioned this previously. I do have the question as to what is the optimal for high-risk patients, but I think for most patients, it's a perfectly legitimate regimen.
Right.
Mary, are patients worried about or troubled by the infusion reactions or the time they have to spend in the hospital chair to get daratumumab?
Yes, very much. You know, especially older patients have no patience.
Patients
have no patience to sit in a chair for 7 hours to be infused IV for like their first, DARA infusion. But I think some of the data that's come out at this ASCO around the subcutaneous DARA injection is quite promising, and that is really going to be, if and when that becomes an approved regimen, is going to be a great improvement, especially for the elderly.
I think at our own centre, I don't think it's caught on in the community yet. After the first 2 doses, so we go to a 90-minute infusion, which is, I mean, it still takes half a day by the time they come in. And
same here. After first cycle we go more traditionally, but we go to 90 minutes, and then sub-Q will likely be moving in. But I want to maybe make a quick comment about high-risk disease and maybe controversial aspect. Should we use proteasome inhibitor in high-risk patients versus antibody? I would agree with Rafael here that we don't have any evidence that one of those two partners is better to fighting high-risk disease. But I would add to that, and it is coming also at this meeting and prior meetings, that ultimately for these people, and has been shown, we have to pick up the strategy which will bring disease to not detectability, MRD negative status. And that potentially supports the choices, which we had discussed at the beginning. Do we personalize treatment or not? I think we should be always thinking that we always help patients with best regimen, no matter what risk. But we have responsibility to give patients with high risk as good regimen to get them to the high level of response.
It feels to me, I'm a bit uncomfortable not having a proteasome inhibitor in the mix at all. I think it's just a matter of time actually before it's both drugs, not either or. But it's going to be, I'm not quite sure what I'm going to do myself in terms of RVD light versus DARA-RD at this point.
I think we're going to do DARA-KRD light. That's going to be the future,
Okay.
right? So it's not going to be, but the key is going to be just to adapt it so that we don't tip patients over the toxicity cliff
Correct.
that so many of them are going for. And there's this tension because traditionally the outcomes for the elderly are worst, but primarily because the treatments are not as good, because the biology of the elderly is usually more favorable. So when you looked at, instead of looking at overall survival, you look at how close can you approximate your life expectancy. Well, you could say it should be easier in the elderly, but it has been harder because the treatments are harder to deliver. But now with some of these regimens, I think if you're diagnosed with myeloma at the age of 75, it's not far-fetched to think that you're going to have a near normal life expectancy. I'm not saying it's perfectly normal. I don't have the data to substantiate that. But given what we see with MAIA and then maybe one treatment of a relapse, many patients are going to get past their 80s. And so we'll see what happens.